All right, it's 4:03, so we can officially begin the healthcare committee meeting. I appreciate everyone coming together. I know it kind of hastily put together at the end of last week, trying to juggle the date earlier this week. I apologize for that, but I do thank you for coming today. I know that we had wanted to get some time for the HSTP project team to discuss more updates since we ran out of time in our last meeting in early March. So first, I'll pull up the meeting agenda for today. So I have it up on my side. Okay, great. Thank you. All right, so it's pretty straightforward today. We can do a brief introduction. We'll appoint a secretary. We'll go through the meeting minutes from the last meeting. We'll open the floor to the project team to discuss their update. If there's anybody from the public that's here, we'll make time for them to talk. And then we'll just got the timeline for the next meeting. Well, I'll go ahead and get started. Brett Hayes, I am a commissioner on the board and also the healthcare committee chairperson. And then you want to move it on to Ernest.
Oh, I am Ernest Covington III. I'm the executive director of the Rhode Island Commission on the Deaf and Hard of Hearing.
How you doing, Ernest? Thank you for joining today. I appreciate it. And then we have Alex.
Everyone, Alex LaFerrier. Excuse me. I'm the outreach coordinator for HSTP, and I'm excited to present on some data today.
We can't wait. We're looking forward to it. Thank you, Alex. Christine.
Hi, Christine West, project director for Healthcare System Transformation Project. Nice to see you today.
You too. Thank you. Bethany.
Bethany Link, contract project coordinator for the commission.
Great, thank you. Especially thank you for your work with the meeting and to share on the screen. A little tedious, but we're really grateful. And then I believe Carmen is also here today.
Good afternoon, Carmen, Rhode Island Department of Health, Disability and Preparedness Specialist.
Thanks for joining today, Carmen. I believe we are great. I believe we also have Bumi. Did I do you? And then we also have Michelle.
Hi, good afternoon. Michelle Zylan from the Office of Healthy Aging. I'm the Associate Director.
Nice to see you today, Michelle. Thank you for coming.
Thank you.
I think Bumi is here, but if she is still muted, we can probably go ahead and get started. I'm happy to continue the tradition of being the secretary for the meeting and summarize what comes from the meeting. And if I can get the transcript from Bethany, as I always do.
I will send that to you after the meeting.
Thank you. And then next, I put together a brief summary of the meeting minutes from the last meeting we had, the March 9th meeting, when we had a colleague from the School for the Deaf come. Her name, Penny Bailey, that was it, Penny Bailey. Sorry, I'm terrible with names. Yeah, so I'm not sure, Bethany, do you have a copy you can share, or would you like me to send it to everybody?
A copy of the minutes. I can share screen with the minutes.
Oh, before you do that, it looks like Caroline joined us. I think you're on mute.
Sorry, I'm late.
That's okay. You were probably out walking in this beautiful weather, were you?
No, I was downstairs feeding my dog.
Ah, nice. Well, good to see you.
Yeah.
All right, and then now we can probably start to look at the meeting minutes from the March 9th meeting. I believe I had the people who attended the meeting, Caroline, myself, James, and Bumi from the committee. Penny Bailey was the guest. And then the staff that attended was Christine, Alex, Bethany, Ernest, and Pam. And I believe Joan and Simon were also our interpreters for the meeting. And then moving down to bullet point 3, Christine made some update to the meeting minute draft copy from the January 12th meeting. We've already submitted that back to the commissioned office. We should be all set there. And then the main event of the meeting was when Penny Bailey from the Rhode Island School for the Deaf joined us, and it was pretty fascinating presentation around a survey project that she did around her healthcare access for the student body with the student and the parent of the student. And I didn't go step by step what she talked about. I kind of summarized it, and Penny offered to share the presentation that we can submit a copy to the commissioner's office for our own record. I did call out a few parts talking about the contentions around students eager to be a part of the conversation in the healthcare setting. A lot of time they are overlooked and taken over by the parent in the room with the doctor or another healthcare employee. I touch upon a Q&A session that we had with Penny based on her finding, and Penny has offered to come back to the healthcare committee meeting in the future if there's any conversations we want to have or continue to have from her finding, or any future project that you might feel we can get good information from her. And then unfortunately, we did not have enough time to really go through any project update last month. So there wasn't much to add in this session. I know we briefly touched upon the interpreter program with Dr. Lynch, and that Alex and Christine had mentioned they wanted to share all of the survey results for the next meeting, which is today. And then I believe Ernest, he touched upon a COVID-19 vaccination program communication at the time, which was a critical topic to get communication and awareness to the deaf and hard of hearing community. And then we offered public comment, and then we ended the meeting at 5:31. Does anybody have any questions or objections? All right. Well, if there's no update, I will revise this one more time, run it through it, and draft a final copy to send over to Pam and Ernest and Bethany. All right, thank you. And we can probably stop sharing that now and then go back to the meeting minute. Point number 4, progress update around the HSTP project. Happy to give the floor now to the project team, Alex and Christine. Is there something you would like to touch upon first?
Yes. Yeah, before we dive into the data, I just wanted to give you a brief project update on what's been happening, and most specifically, the project website. I'd like to bring that up for you on the screen just to make you aware that that website has been created. And so whatever it is that we don't cover in today's meeting for the data for both of the surveys, you can find on your own at the website. So I just want to share my screen with you to show you what that looks like. and hopefully folks can see that. So this is our HSTP website. You can find it at cdhh.ri.gov/HSTP. And as you can see across the top, we have our home landing page, which we have here. Please feel free to take a look. We also have our 3 tabs here for our 3 project goals. So we have data collection, and that includes national and state data, including a timeline of health surveillance that's been done throughout the state regarding the deaf and hard of hearing community. We also have our survey for Rhode Island healthcare professionals that Alex will be going into. And we also have our survey for the deaf and hard of hearing community. For our second goal, we have workforce training, and you can see some of the activities that we're working on there. And then finally, workforce development with the sign language interpreter program. So just wanted to make committee members aware of the website. So during your free time, if you want to take an additional look at what we've been doing, all of the information is here. The second update I wanted to provide is both Alex and I had the wonderful opportunity to present to Perspectives Corporation both yesterday and today. So we've been very busy with that. Yesterday afternoon, we did a 2-hour presentation with deaf and hard of hearing staff there, including their full staff for the deaf and hard of hearing programs. And then we also presented again this morning from 9 to 11 to Perspectives, and it was very well received, and we were very happy to have the opportunity to present to those folks there and share a little bit more about the project. I also wanted to share about the interpreting program. The program has been officially approved by the Post-Secondary Ed Council. So even though the grant outlined establishing an interpreting program for the community, it wasn't officially approved till just a week or 2 ago by the Post-Secondary Ed Council. So we have the green light to move ahead with it. We've been working very hard, and we do have some additional updates in terms of marketing, as well as continued program development. But we wanted to share the news with you that it is official. It has been approved, and we're looking forward to additional progress on that. There are actually 3 programs that have been approved related to interpreting. 1 program for ASL interpreters, 1 for Spanish interpreters, and 1 for Portuguese interpreters. So 3 brand new interpreting programs at RIC. So we're excited to be amongst those folks and look forward to some cross collaboration with those spoken language interpreters as we move forward. So just wanted to share those brief updates before we dive into the data. What we can do first, I guess, is start off with Alex, if you want to talk about the survey for healthcare professionals that we sent out. Would you like me to bring it up on the website, or did you want to bring it up on your end, Alex?
We can see what it looks like on the website. I figured we would go
Okay.
through each
Okay.
slide, each portion.
Sure,
Is
great.
the website live?
I'm sorry?
Is the website live?
Yes,
now?
it is live. Yep.
Awesome.
You can go ahead and access it. Yep. And before we get to the surveys, I just want to point out under national and state data, as you know, we were required to compile some baseline findings. So what we did was compiled a timeline, as I mentioned, of previous research, data, and surveys that were conducted in the state for the deaf and hard of hearing community. And all those are broken down by year. So you have a timeline going all the way back to 1982 with Jeannie Panarace, for those of us who were around back then. And then it continues on into the future. So you can see that timeline all the way up until present day. And so I hope folks will feel free to take a look at that information because we finally have it archived. As opposed to being in separate files at the commission, we have one consolidated place where we can archive this information. So I hope folks will take a look at it during your free time. So jumping into the survey for Rhode Island healthcare professionals, we will jump into the survey results. All yours, Alex.
Sure thing. Can we zoom in a little bit, try to fill
Sure.
the screen? Figured we would go a little bit more if we could, please. Want it nice and big. Okay. So as Christine mentioned, we're warmed up After presenting to perspectives, we didn't do a deep dive. We started to scratch the surface. So healthcare committee's lucky that we're ready to present in full force. This data is gonna take us on a little journey, and it starts off with demographics. So I figure it's gonna look like a graph, and then the graphs will be broken down into deeper options. So with this first one, we are looking at the demographics of what the survey participants are. And we can look down at the breakdown in which 43%, the majority, ironically enough, are other, where the one we're most concerned with is doctors and nurses, which make up about 50%. So begs the question, success is one of the first things I've noted to myself. We've reached 50% doctors and nurses, which I think is very critical for our healthcare system transformation project. And then to break down the other even more so, if we can continue scrolling, these are just a slice of what the others break down into, with a majority being social workers. This is the line by line item of every other contribution. But the next is social workers at 16%, psychologists at 8%. So you're looking at a span of healthcare workers. Like I mentioned earlier, 50% being doctors and nurses, and then the next breakdown being social workers and psychologists. So that's going to frame a lot of our thinking as we move forward to imagine 1 out of every 2 answers is from a doctor or a nurse at 50%, which is great to think about because that's our target audience here.
Great, thank you, Alex. I just wanted to add to this. When you look at the other, we have quite a range of healthcare professionals that are responding from, as Alex mentioned, doctors, nurses. We've got social workers, physical therapists, hospital administrators, certified nurse midwives, CAT scan, X-ray technologists, program managers, psychologists, firefighters and EMTs. So we have first responders, we have pharmacy technicians, respiratory therapists, massage therapists, dental hygienists. So it goes on and on. It's nice to have quite a range of individuals who are responding.
It even shows the success of the survey reaching beyond non-healthcare fields, which is a great start in terms of making change in other areas, but that's beyond the scope of this project right now. Eventually we'll get to question number 2. We just keep scrolling all past
Getting
all this,
there.
please.
Here we go.
I'm not sure if anyone else sees that. It's frozen on my end.
I can see it.
Yeah, I think so.
Can folks see it?
It appears frozen, Christine.
I
Yeah,
can't
it's not
see it.
moving.
Hold on, let me see. Let me bring that back up. Sorry, it might have been too fast. Is that okay?
It's getting there.
Taking a moment.
I've been having technical problems today, so. Folks able to see that yet?
Nope.
Not
Alex?
yet. Not
No.
yet.
No.
Alex, did you want to bring it up on your end?
Sure.
Okay.
I have some slides here, which is what I was planning. So I'll go ahead and share my screen here. I think people should be able to see this. Is that correct?
Yep, we can see it.
So here's how I was going to go through it with my slides. It's obviously more encompassing on the website where you see each line by line item here. This is compiled down into social workers at 16%, like I said. Okay, so if we move on, my primary place of work is in. Here's the nice graph where it shows the percentages broken down visually. And if we look here in the numerical breakdown, hospitals and other are the 2 leading places of work, which is great for our healthcare survey concerns. And if we go down to look at what those others broke down into, schools is the number 1 other choice. than nursing homes and retired. I'm not going to go into every line and discuss everything. I've written specific notes on specific slides because we have 58 points of data to go through. So for the sake of this meeting, we're just going to look, and then I'm going to make a comment and then extrapolate where needed. But just to give you an idea, we're looking at 50% doctors and nurses that take place at 50% in the hospital. So this is framing our data. Which county are you located in? Visually, predominantly Providence. Big city data, big city progress, doesn't speak to a lot of the counties outside of the city. So something to keep in mind. These are progressively minded city dwellers that are aware of this survey and answering accordingly. Followed by Kent, so on and so forth. I am a female, large representative here of our data. So these doctors and nurses, or at least the ones that are responding, are 78% female respondents, which is sort of in tandem to a lot of deaf community, deaf culture norms, the large predominance of female workers in deaf culture and deaf community. I wonder if this is reflective of some sort of gendered norm where female mindset has a tendency to want to engage and share data as opposed to the male mindset that maybe is a little less receptive or less engaged with data, or willing to share at least, especially in a healthcare field, which is predominantly dominated by men. This is quite a surprising response. You would imagine the male population would be a lot more respondent when 50% of it are doctors and nurses. But just something to keep in mind is female doctors and nurses in Providence, so on and so forth. So this is expanding our story as we continue forward. My age is a beautiful bell curve here of age distribution, centered around 50 and 59%. And if we look at the percentages, not as easily visually displayed, but my note here is 50 to 59% makes sense for a healthcare field, which is a largely older population of employment, and doctors need a lot of education, and it's a field that requires a lot of maturity and so on and so forth. But it will reflect the mindset of people who have some willingness or are willing to admit their understanding of deaf culture, and it may not be indicative of the larger youth or progressive mindset that exists in a more youthful environment. So this, I think, is a good thing to recognize, that the survey respondents are showcasing knowledge from over the course of 50 years, as opposed to a more modern progressive mindset of a youthful mindset. I also noted that we had 0.13% of 90 plus. So 2 respondents were over 90, never stopped learning. Thank you for those respondents who are willing to engage even in their later years of life. So I thought that was kind of neat to have in our survey. Okay, have you had prior exposure to deaf or hard of hearing people? Resounding over 90%, which is great. This is a big step. You would imagine having the opposite answer would be a very terrible thing to have to engage, because, oh my goodness, there are deaf people in the world, and how come over 90% haven't engaged them at all? I would admit that, is this a broad question though? Exposure in the movies, on TV, in your life. So take the 90% of exposure to deaf or hard of hearing people with a grain of salt. You know, I saw Switched at Birth. I have exposure to the deaf community. I'm good to go is not necessarily a yes answer we want to chalk up as success. So keep that in mind. Has there ever been a deaf or hard of hearing person in your social circle? A little bit more alluding to people's day-to-day interaction. And this is split almost 50-50, 52-47. This is interesting to know. Yes, there's a 10% split. So 90% deaf or hard of hearing making their way in people's lives. I'm reading my note here, it needs to be a little bit refined. So consider 1 out of every 1,000 babies born are deaf or hard of hearing would make this kind of an interesting statistic, in which 90% of people said no, that they don't. So are you aware that there is a deaf culture? Yes. That's a good answer. That's great. That means deaf culture has a presence here in our state of Rhode Island and the cities, according to the female doctors and nurses of Providence. Have you taken American Sign Language class? No. Predominant answer, which is, that's unfortunate. That's a sad thing because we would love to have more people take American Sign Language class for the sake of humanity and the sake of our Rhode Island deaf community. But at the same time, a predominant deaf culture theme, never taken ASL, but I would love to, is a resounding yes.
If I could just add to that, Alex, I think that's an interesting point that we have, 70% of healthcare providers who want to take an ASL class. So I think we see opportunity there, that if that kind of capacity could be provided to them somehow, providing ASL classes to nurses, to doctors, if that were ever to present itself, that's a great opportunity because it sounds like people want it.
Right. Maybe they just don't have the formal avenue or resource or ability to take a well-structured, well-focused class. So that's great to point out that the demand is there. We just need to provide the supply.
Right.
Here's just the numerical breakdown. So do you know how to request a sign language interpreter? Almost 60% said yes. So that's a great thing to know, is our doctors and nurses in the city of Providence around the ages of 50 to 59 know how to request a sign language interpreter.
I just wanted to add, we have almost 41% who do not know how to request a sign language interpreter. And so I think there's opportunity there too for some more education about knowing how to go about requesting interpreters. And as we know with Penny in her presentation last time, talked about parents and not knowing the process and coming up with that infographic that she made. So again, more opportunity for education on behalf of the commission with healthcare providers.
Right. It would be an ultimate goal to get that to 100% know how to. And we are rid of 40%, almost 41% that do not know how to, especially in a healthcare setting.
Hi, this is Brett. Do you think that is more of a, is that more on the provider, like the company that provider works for, or is that more on the provider themselves, the healthcare provider, to learn that? Did that make sense?
I believe it would be the onus of a healthcare provider to know how to request a sign language interpreter. That is a must, and we are working on those training modules that, one, address that it's the responsibility of a healthcare worker to request an interpreter. Two, how to go about that through formal channels, through the commission and services that the commission refers to, so on and so forth. So do they know how to request a sign language interpreter? Sure. Does that mean they know how to do it through the commission? We don't know that specifically. Do they know how to call up an interpreter agency through informal channels? Like we want to clarify that. We want to actually bring clarity to that.
Yeah, and also to add to that, each facility may have a different policy and procedure in terms of requesting interpreters. So do these healthcare providers know, and are they familiar with their site-specific procedures? Do they contact the interpreter services office within the hospital? Or if that doesn't exist, if it's a primary care physician, do they know how to reach out to appropriate agencies to make that request? I think the most important thing is, do these individual healthcare providers know the processes within their own facilities, even though those facilities may vary in their processes?
Right. And maybe the doctor says, yes, I know how. I asked my secretary, but does the secretary know how? Or, that's not solving the problem. So this answer might actually be a little bit skewed, and no is actually a larger percentage. It's just misrepresented because of one's error in knowledge. So that's a lot of things that we need to address.
And this is Carolyn jumping in just for a minute. I need to go back. I don't need you to go back on the slide, but I'm referring back. So a significant proportion of people said they had never met a deaf or hard of hearing person. Considering the high prevalence of hard of hearing, I'm just shocked. And I know that being hard of hearing is kind of even some ways more invisible than being deaf, but it makes me want to wrap them across the knuckles because they have people in their lives, their families, their friend circle who are hard of hearing. So shame on them.
Yes.
Do you think that might be the misinterpretation of what a deaf and hard of hearing individual is? Do you think maybe they don't realize that might also include family members with hearing damage from music or late deafened? Do you think it's a
Well,
possibility they're not considering that?
sure, Brett. And I think it shows that you're a much nicer person than I am. I'm a little more militant about this because it just irritates me no end.
No,
That's a,
I was
that's a
just
very,
yeah.
sorry, that's a very deep philosophical question of identifying deafness, and that's beyond the scope of this project right now.
No, I know, but I want to make sure that as a hard of hearing person, I'd like us all to be represented.
Absolutely.
And I know that sometimes it's something as simple as the doctor not turning his or her back when they talk to you, that kind of thing. So.
Right.
Yeah, I think you bring up a good point, Caroline, about what is the perception of medical providers in terms of looking at deaf and hard of hearing people. Who do they consider to be a part of this group? And if they're not considering certain people to be a part of this group, why is that? What's informing those perceptions and that kind of decision making? And there's opportunity for training there as well.
Right. I think a lot of people think if your speech is clear, you're not deaf or hard of hearing.
Right. Right.
Right. All right, we're gonna progress along.
Right.
It's okay. Are you aware of the difference between sign language interpreters and certified deaf interpreters? A big resounding no, and that's quite unfortunate. Maybe a byproduct of CDIs becoming a recent phenomenon in the past couple of decades. So, playing devil's advocate here, but this is a huge issue that needs to be addressed, as CDIs are critical, especially in a healthcare field where there's very specific terminology and very specific cultural understanding to transmit to the variety of deaf community members. So this 83% is an unfortunate statistic.
Yeah, and just to add to what Alex said very well, in fact, certified deaf interpreters are actually the original interpreters. They have been working as interpreters since the dawn of man and women. So they were the original interpreters. Hearing interpreters are the newbies to the field. As we know that deaf individuals have served as interpreters for their own classmates growing up at schools for the deaf when they were unable to understand hearing teachers. And so we know that CDIs are the original interpreters in the field. And the fact that we have healthcare workers who don't understand the difference between a hearing and a deaf interpreter and understand the value of a CDI and what a CDI can bring to that particular healthcare event, I think is really important and merits a lot of education.
And this might not even speak to the bias inside the mindset of a deaf person cannot be an interpreter. The quote certified deaf interpreter, we know it, hopefully, to be a deaf individual who serves as an interpreter, but this very well could be read as simply an interpreter that I assume is hearing. They are a certified deaf interpreter, so that's, and even if it was perceived as a normal quote unquote hearing interpreter, there's still 83% willing to admit they do not know what that means.
Right.
Okay, moving on. We're starting to get in some meat of the matter here. Are you aware of video relay service? Almost 60% says they are not aware of video relay services, which is unfortunate. Never mind not having access to CDIs as a resource or an understanding. Now we're getting into the technological misunderstanding of having the ability to provide interpreters via relay or connecting via relay services to deaf patients abroad. This isn't VRI. We're getting to that next, but to know that they cannot even connect to the deaf community via VRS, video relay services, or video technology to communicate with them directly.
Yeah, agreed. And this is important when a deaf individual is trying to schedule an appointment with a physician or trying to call into the hospital to get information. And if we have folks who are working in those facilities that don't understand VRS, don't understand when they're getting a call from a deaf person and decide to hang up, obviously that causes frustration on the part of the deaf consumer. So we can see where there's more opportunities for education here too.
Right, and the practices and protocol that go into using VRS, whether that's pacing or understanding the intermediary and what is actually happening in that pipeline, which again our workforce training modules address very visually, which is great. So here's the numbers here. And I also brought up as well too, which is unfortunate because technology has developed thanks to the deaf community for numerous years. And I wrote down, does anyone remember the Sidekick, the precursor to pagers and smartphones? And we have the deaf community to thank for this sort of technology. So even in the medical field, which is a constantly evolving medical or a technological field, they are not aware of the VRS as a service. So it's unfortunate. And here we are again, with VRI, over a resounding 60% no. So never mind knowing that we can communicate through video technology with our patients. We do not even know we can provide interpreting access in the healthcare field through technology. And that's a huge knowledge gap as well too. Okay, now we're getting into the services. Are you aware of the commission here in Rhode Island? Over 50% say yes, but more importantly, almost 50% say no, which is very problematic. This is a valuable resource here in Rhode Island and one that mediates in between the community and healthcare providers in terms of resources across the spectrum. It would be nice if our cities, if our hospitals and doctors and nurses knew about the commission. I'm sure it would alleviate maybe a lot of their concerns with trying to provide interpreters or learning about VRI, VRS, etc. Especially, sorry, go for it, Christine.
Sure. And just to add to that, even knowing about the EPCAT program, which was created and exists in order to provide training to healthcare providers, among others, including first responders. So knowing that this resource is available for future training opportunities, that would be important too.
A cochlear implant, don't know. We'll get to the next one. It's a little easier to read. So a cochlear implant will allow, you can read it here for yourself. A majority of people believe a cochlear implant, they don't know what it does, which is maybe the safer answer, but a little bit more shocking. The next answer is number one, will allow a deaf adult to immediately begin hearing and understanding oral conversations at 400 respondents, 26%. So that's very shocking to think that healthcare providers, doctors and nurses in the city of Providence, Rhode Island, believe that a cochlear implant will immediately do this for a deaf individual. And the converse 16% thinks it will destroy hearing, any residual hearing that a patient has had left, which I believe might be technically true, but it's interesting that that has collected 240 responses.
Hey, Alex, if you don't mind me asking, what's the point of this question? Is it like to see what they think they know the answer to cochlear implant?
So the instrument that we have borrowed from the University of California, San Diego, led by Dr. Georgia Sadler, who built this tool in order to gauge deaf culture competency of healthcare providers. So this tool was very critical for us because that's exactly what we wanted to gauge here in Rhode Island, to better see what the current understanding of deaf culture abroad and specifically here in terms of technology, to better address where their knowledge gaps are. So if 100% of people says, corrects for any type of hearing loss, we can interject with our modules and say it does X, Y, and Z, or is desired by 100% of people think it's desired by 90% of deaf people. We can step in and say X, Y, and Z. So the answer here being 45%, they don't specifically know. That means our workforce training module will address the spectrum of answers here and why one is more correct than the other, or why one is not 100% truthful, for the sake of their knowledge and how to better address it when the concern is brought up among patients, when concern is brought up amongst parents, so they're better able to answer these questions more truthfully for the sake of the community long term.
Oh, Alex, I need to correct something I may have misunderstood. I thought that when a cochlear implant is implanted, that the ear that is implanted does lose any residual hearing. I thought the acoustic nerve was cut. Is that incorrect?
I believe that is the correct answer for this question, Caroline.
So they do lose it in the ear that's been so-called treated.
That's my understanding, correct? I
Okay,
believe
all right,
that is the correct answer for this question.
Yeah, that the shoe that drops when you try to go for a cochlear implant. If you have some natural hearing now, that you lose it altogether, and you lose the rest. And if it doesn't work at the cochlear implant, then you lose everything.
Right. But as Alex was saying, you can see from the results of this survey, from the responses, that only 15% of healthcare workers understand that. And you can see that most, as he said, don't know what a cochlear implant does and how it impacts any residual hearing that the patient might have had. There's an assumption that 12%, by 12% of healthcare workers, that at least 90% of deaf people desire a cochlear implant, and that 26%, 400 individuals, think that a cochlear implant will allow a deaf adult to immediately begin hearing and understanding oral conversations. And we know that there's a lot of work that happens post-surgery with mapping and speech therapy before someone can begin to do that. So we can see that there's a lot of misunderstanding out there, even amongst medical professionals who you might assume would know a lot about cochlear implants. What we're seeing is that there's a lot of misunderstanding about it.
Right. And the survey clearly stated, if you do not know, please select do not know for the sake of our understanding. So people confidently selected A, will immediately allow a deaf individual. So that's 26%, which is a staggering result. All right, moving on. In a medical setting, it is the right of the deaf patient to answer 2 here, which we'll expand upon, is the leading answer, to be provided with an interpreter by the practitioner. So that's a comforting statement, that almost 75%. Obviously, we would love that to be a 100%, but we're more interested in the 12% that don't know the rights of the deaf patient. You know, right. that needs to be corrected.
I think with this question too, there is the possibility of a couple of other answers that could have been chosen. It is the right of a deaf patient to express a preference for a particular interpreter. They do have that right to some extent. It doesn't mean that the healthcare provider must provide that particular interpreter, but they certainly have the right to express it. And certainly the deaf patient can decide how much personal information they want to disclose in an interpreted situation as well. So for this particular question, even though number 2 is considered the correct answer, both the first choice and the third choice could also could be considered quote unquote right answers as well.
Right. It's just interesting to see where the data falls to see what are people most likely to believe in or pursue or elevate.
Yeah.
Well, and I also would wonder, if you got to a question about whether providers understand about certified interpreters, because I have seen family members put themselves forth as interpreters, or neither screened nor certified people putting themselves forth as interpreters. The deaf person may prefer them, but I would think the medical provider would want the qualified person, if only to protect their own professional integrity, not open themselves up to liability.
Right. There will be a question that addresses using a family member.
Great, thanks.
Yep. So this next one's a bit of a long one. In a nutshell, it's addressing deaf culture. What is the best way to gain a deaf room's attention. And if we expand upon it, number 3 is the leading answer here. Our healthcare professionals believe that you should ask the interpreter to sign that you are ready to begin. I believe the most deaf culture answer is number 2, flick the lights to gain people's attention. So it's interesting to see the interpreter become a device or a tool here, or a position of authority. Not necessarily wrong. It just seems interesting that healthcare providers are more willing to utilize the other human subject in the room to do what they could easily do themselves by, flicking their hands or flicking the lights. So I think this just summarizes a lack in deaf culture knowledge.
Yep.
Okay, moving on. Let's see here. Another deaf culture question: where should the patient and interpreter sit? So number 2 here is the leading answer.
I believe number 3. Oh, sorry. No, you're right. That is the leading answer. But I believe the correct answer is the equal distance.
Right. Okay, moving on. You have a deaf couple who refuse their newborn baby's hearing tested. Yeah. Who refuse to have their newborn baby's hearing tested. You should split here between don't know and number 2. Inform them that it is their decision, but explain that this lack of knowledge will put their baby at risk. I think the other answers are far more fascinating, that gain attention, that it is required by law or accept their decision. Seems to be the trailing answers, and doctors are led with the concern of risk, even though allowing them their decision. I just think that's very indicative of a pathological sort of mindset, as opposed to respecting people's wishes. And then obviously don't know is a leading factor as well. Maybe the safest of all 3 answers. So maybe healthcare providers have a way out of saying they don't know rather than picking the wrong one. But nevertheless, almost 40% pick number 2. All right, moving on. So you're in the emergency department. Call for a patient several times. Others in the emergency department reading a magazine, they tell you she's deaf. You should. Deaf culture 101. Number 3 here gets the answer. Approach the patient, making small gestures. It's good. But I still think it's interesting. People are willing to just call their name louder. I guess that is indicative of their willingness to use that option. 14% don't know.
And I think, there's also the approach of gently tapping on the shoulder, which could be the more effective answer in this case. Certainly, you could have either. You could have gently tapping someone on the shoulder, or you could have someone making small gestures in the field of vision. So here again is another question where you could have some answers in both categories. And we can see that the highest number of responses were in both of those choices.
All right, moving on. So just giving you time to read the question here. You have a child, documented hearing loss, risk factor. They require to receive additional follow-up testing. You should, predominant answer, explain to parents the importance of receiving hearing screening follow-up. That's best medical practice. That's probably the overwhelming answer for a reason. But again, we have almost 20% don't know. I still think that is sort of an out, but at least we know there are people who are willing to admit ignorance as opposed to feign knowledge. Here's a fascinating one. So the question: only 30% of English language can be accurately lip read. Our 1,500 medical care providers don't know. Overwhelmingly don't know. probably because when a question asks a very specific number, if you want to game the game, it can't possibly be true because it's a specific number. But point being is they're not willing to go true or false one way or another. And I think if this was the mainstream perspective of only 30% of English can be read on the lips, that could be a quote unquote true statement, but they aren't willing to admit that specific fact. So I'm glad that they aren't willing to say that it is true one way or another.
Alex, I didn't want to interrupt, but I see in the chat room that we have a reminder that the interpreter is scheduled till 5 o'clock.
Okay.
It is 4:53, so we have about 7 minutes left.
Okay, we're only halfway through these slides. I knew this was a big chunk of data. So if we all want to vote on what to do, I'm willing to silently just scroll through each slide for the sake of us having exposure to it. But I know each one can have a discussion in length.
I think the other thing we can do is if folks want to take a look at it on the website on their own, and then at our next meeting, if there are any follow-up questions, we'd be happy to answer them at that time. That might just save us a little bit here in terms of the time that we have left.
Okay.
Yeah,
So,
either schedule another meeting sooner than later, like if you want another hour to look at the data again.
I guess that's up to you, along with the committee members, is how much you would like to go through the data together and be able to talk about it, or if you feel confident in looking at the data on your own and during our next meeting, discussing it then. It's up to you in terms of how you want to approach. What would be most helpful to you?
I think for me, I would probably want to look at the data before the meeting, and then we can all come together and talk about what we can take away from this data and how we can interpret, how we can turn it into action between the committee and the commission.
yeah, I think for our project purposes, we are acting on this data already. You know, it's nice for us to report out, but HSTP is focusing in on knowledge gaps, you know, ingesting, incorporating this data. It's you know, driving our actions from here on out. It's great for the healthcare committee and the commission to know about it, but you know, we can walk through it and have these discussions, which I think are informative. But that HSTP is moving full force ahead, which is great on this data.
Yeah, and just to add to what Alex said, we took the results of this particular survey that he just shared, and we identified the knowledge gaps. And now we're in the process of compiling a series of virtual trainings that will be made available to healthcare providers in response to these knowledge gaps. And you can take a look on our website under workforce training. You can look at virtual trainings for healthcare providers, and there are 12 different trainings that we have compiled. So we're in the process of creating those trainings. Alex is knee deep in editing them, and we'll have them interpreted in captions so they are accessible to everybody. So that was a part of the project deliverable, is that we use this survey as baseline, identify where the knowledge gaps are, address those gaps through workforce training, and the results will also be included in that final consolidated report that we will also be making. With the 3 minutes that we have left, I just want to give you some brief overview of the deaf and hard of hearing survey.
Okay.
And so I'm going to go through it really fast, so bear with me, Tina. Our sample consisted of 105 deaf and hard of hearing adults. As you know, the survey had 2 different parts. The first part, we had 130 respondents. And then the second part, we had 101 respondents. However, this sample consists of 105, and that's due to the fact that we had to account for variables that had at least a 90% response rate. However, that sample size is significant. We had a mean age of 49 years old, and that age range spanned from 18 to 86 years old. The sample consisted of 61% female, and 38% male, and 1% non-binary. We had about 74% of respondents who self-identified as white. And looking at the racial demographics, they align with the general overall population of Rhode Island. So when we look at the overall population, we have about 75 to 80% individuals who are white. So our survey falls in line with that. We had 45% who indicated they had a college degree. So that's a pretty high number amongst this particular sample size. 57% reported that they had a job, so that they're employed. Half of the sample owned a home. In terms of deaf identity, we had 38% self-identifying as culturally deaf. We had 45% identifying as deaf and 18% hard of hearing. So when you take into consideration 38% and 45%, we're talking over 80% of respondents identify as either deaf or culturally deaf in this particular sample. 18% hard of hearing. We would have liked to have seen those numbers much higher, considering hard of hearing folks comprise the majority of the deaf and hard of hearing community. Of note, in terms of health outcomes, we have 34% who were classified as obese, and this is according to BMI. We had an additional 38% who were considered overweight. So when we take those two percentages together, we have about 72% of respondents classified as either obese or overweight. So this has implications for behavioral health. Medical conditions, when we look at depression or anxiety, folks who have been diagnosed with this particular condition at some point in their lives, 43% of the sample size. So quite a high number has been diagnosed. Hypertension, 34%, arthritis, 35%, diabetes, 26%, so about a quarter of the sample size. Lung disease and asthma, 22%, cancer, 11%, liver and kidney problems, 11%, heart condition, 7%, stroke, 6%, and COVID-19, 5%. We had about 35% visiting the emergency department. And we have, let me see what else. About 95% of the sample indicated that they had some kind of insurance, whether that's private insurance or Medicaid. 89% reported having a regular provider, and out of that group, 38% used interpreters and 42% communicated directly, either in sign language or English, while 20% used writing or texting. So all of this information is broken down in greater detail on our website. Again, we hope you have the opportunity to take a look at it. And this is certainly informing us of future needs for health education, health literacy, and that's something that we're currently working on now in our discussions with the Department of Labor and Training to see if we can address opportunities for health education in the future for the community. So I know we're past time, 5:01, and we need to let the interpreter go. So we hope you take a look, and I guess we'll reconvene back at our next meeting. And if there's any questions, both Alex and I will be more than happy to answer.
I really appreciate it. Thank you so much. And I will definitely look at the result, and I'll try to set up more time for the group sooner than a month from now to look at these results some more and potentially talk about more topics. But a big thank you to you and Alex. I did a tremendous job. Really excited about the website. This is great. So definitely want to take a look at your work, and we're really excited about the workforce training module as well.
Great.
All right. I don't think we had anybody in the public in this meeting, so we'll opt that there. And then, like I said, I'll schedule another time for the group to get together. And with that, I'll let everybody go and hope you can enjoy your night.
Thank you.
Thank you, Christine and Alex.
Bye, everyone.
Great job.
Thank you, Bhumi.
Thank you.